time as we can. I apologize, they might shorten your break on the back end of it. Obviously, if you need to go take a break or get anything, feel free to hop out of the class. All right, so NAFLD. We'll talk about this just very briefly, but NAFLD is the spectrum of disease, right? So it's anything from isolated steatosis all the way to cirrhosis and HCC, okay? It is basically, the definition in the medical literature is evidence of steatosis, in hepatic steatosis, either by imaging or histology in the absence of secondary causes of hepatic fat accumulation, okay? So basically what it means is there's fat in the liver and we found it, bottom line. And there's nothing else that's going on in the liver, right? NAFL, NAFL is isolated steatosis. This is just fat that builds up in the liver. There's nothing else going on. And then you have its cousin, its progressive form of the disease called NASH, NASH, non-alcoholic steatohepatitis. This is basically the progressive form of the disease where you get inflammation and damage to the liver. And the hallmark of that damage is something called ballooned hepatocytes, which we pick up on histology. Then you have the cirrhosis and the hepatocellular carcinoma. But that's old nomenclature. We've gone to the new nomenclature. So we have what's called steatotic liver disease, which is the overarching umbrella term for any sort of hepatic fat accumulation, okay? And then you have subsets of that. The new NAFLD, or the new NAFLD, is called MASLD, Metabolic Dysfunction Associated Steatotic Liver Disease, right? So all of these are going to end with steatotic liver disease, SLD. Then you have MetALD, which is combination of MASLD plus alcohol. And then you have alcohol, which can cause steatotic liver disease. Certain conditions and genetic conditions, drugs, viruses can cause steatotic liver disease. So the steatotic liver disease is the overarching term, but we're going to focus on far left corner, MASLD. If you want to make the diagnosis of MASLD, you have to see first evidence of steatosis in the liver, and then patients have to have one cardiometabolic risk factor, just one, okay? And what you'll notice is it's a BMI of 25, which is, as we said in the last talk, it's overweight. So you don't need to be obese, you have to have at least overweight to be diagnosed with MASLD, right? Or it's abnormal handling of blood sugar, right? Any version of prediabetes, diabetes, all that kind of stuff goes into the diagnostic criteria. High blood pressure, greater than 130/85, or dyslipidemia. Dyslipidemia is two things. It's elevated triglycerides and it's low HDL, okay? You need to have one of those to meet the criteria for MASLD. But other things can be going on, right? So you'll see here on the pathway it says, are there any other causes of steatosis? If you say yes, then it could be from alcohol, it could be from drugs, it can be from multiple different things, right? So you can have multiple things causing steatotic liver disease. If they don't have any other causes and there's no other cause of steatosis, this is what we call cryptogenic steatotic liver disease. Usually this is people who haven't yet developed those cardiometabolic risk factors. They're like early MASLD, basically. All right, this is the progression of it. So you see healthy liver to MASLD, or isolated steatosis, to MASH, and then you have cirrhosis. Now, what you'll notice at the bottom is this is all reversible up until about the cirrhotic stage. We used to think cirrhosis was irreversible. Largely it is, but we're starting to notice that you can actually reverse some level of cirrhosis, okay? So it's not 100% irreversible, but it's damn hard to go back once you hit cirrhosis. When you're talking about biopsying it, we have this called NAS score, NAFLD activity score, okay? This is the things that we're going to look on the biopsy to tell us what the NAS score is, and that will tell us how bad it is, okay? Steatosis is graded based on the percentage of the liver that has fat in it. So stage 1, 2, 3, it's all right there for you. Lobular inflammation and ballooning hepatocytes are what we're going to see in MASH. So that's what you're going to see in that like progressive form of the disease. So once again, the hallmark of MASH is that ballooned hepatocyte. You have to see that in order to diagnose MASH. And then fibrosis, we'll talk about later. That's how much scar tissue has developed within the liver. So a couple of pictures up here. Up at the top left is a normal healthy liver. Top right is MASLD, so you just have isolated steatosis. Those little white droplets in there are fat droplets that show up in the liver, okay? So that's just fat. There's nothing else going on there. Bottom left is MASH. This is when you get in those ballooned hepatocytes. So you've seen that little insert right there. You have a ballooned hepatocyte. Basically, it's big, and it looks like it's about to pop, basically. And then bottom right, you have fibrosis. That blue stuff in there is the scar tissue that's starting to develop as a result of this inflammation and damage that's going on to the liver. The way that you can think about this is first you get the fat that deposits in the liver, and about 30% or so of people who have isolated steatosis are going to progress to MASH. When you have the damage, the ballooned hepatocytes and all that kind of stuff, it's like you're getting cut in the skin or you're having damage anywhere else in the body. The body's going to see that and is going to want to try to heal it by forming a scar, right? But the problem is once the scar tissue gets out of hand, then you replace the liver with scar tissue, which is what cirrhosis is. It's the fibrotic replacement of the liver with scar tissue. All right, another example of what it looks like histologically. You can see on the left-hand side you have what's called alcohol-associated steatohepatitis. That is basically what happens when people come in with alcoholic hepatitis, okay? It looks identical under the microscope to MASH, with the exception of you get cholestasis with alcohol. You don't really get the cholestasis with the MASH, okay? But overall, they look very similar under the microscope. All right, we'll run through epidemiology real quickly. It's like obesity. It's high and it's getting worse, okay? One study was done in 2019. It was a prevalence study. It looked at 245 studies, 5.4 million people around the globe. Globally, the prevalence of MASLD, just MASLD, any stage of it, is about 29.8%. In the US, 35%, okay? So it's high and it's getting worse. When you look at prevalence of low risk to moderate risk, fortunately, most of these are going to be low risk. But you still have about 20% of the people that are going to be high risk. This is what it looks like as far as the heat map from that one study is concerned. You can see, obviously, in the Americas, a lot more prevalent than other areas of the world. Although I don't think a lot of the studies came from Africa. So some of these data, I think I would say take with a grain of salt. Now, when you're talking about MASH, I'm using the old nomenclature up here because the studies were done when they used the old nomenclature. But when you're talking about MASH, it's harder to diagnose the prevalence of it or to determine the prevalence of it because you need that biopsy, okay? So there's a couple of studies that can help us determine the prevalence of it based on what they did at the time. There was one study that looked at a cohort of patients with NAFLD who had an indication for liver biopsy. That usually means that you're concerned for MASH, right? So they had a clinical indication for a liver biopsy. 59% of them had MASH, right? But if you take that same cohort that didn't have that clinical indication, a lot less, 6.6 to 29%, right? So it depends on the patient that you're looking at. There was one study that was done here in San Antonio by Dr. Harrison at BAMC. It was a very clever design. We had these colorectal cancer screening classes, and so every time people came in ready to have their colonoscopy, they went to the class, they learned about the colonoscopy, and he said at the end of the class, he said, hey, does anyone want to hear about their liver health? And they had some people raise their hand and said, has anyone ever been told anything about the liver? And he took people that didn't have any history of liver disease, had never been told there was anything wrong with their liver, and he biopsied them. 14% of those people had MASH, just in the general population in our area, right? Never been told they had any disease or anything like that. So it's out there. Overall, in the general population, we think it's between 1.5 to about 6.5%, okay? Now, when it comes to liver transplants, it's getting worse as well. So previously, alcohol used to be #1 cause for transplant in the US, right? It still is overall, but when you're talking about people over the age of 65 and women, MASH is now the most common cause for liver transplant, okay? As far as HCC is concerned, the rate of HCC in MASH is pretty low. It's about 0.44 per 1,000, but because it's so prevalent, the disease is so prevalent, you get 14% of hepatocellular carcinomas are from MASLD MASH, right? It's just because the disease is all over the place. All right, so what happens? The first thing that you have to do in this is you have to load the liver with triglycerides or with fats, okay? And that comes from two different places. That comes from de novo lipogenesis, so you eat something in the diet, and the liver takes that and it synthesizes these free fatty acids from that. The other part is from lipolysis from adipose tissue. So basically, when you get adipose tissue dysfunction, you get these free fatty acids go into the circulation and it comes to the liver, and the liver takes them and it turns them into triglycerides, and it stores them in the liver as triglycerides, right? So de novo lipogenesis and lipolysis from adipocytes is where you get the fat that builds up in the liver. When you're digesting those fats or just having them hang around, you get these lipotoxic species that can cause lipid peroxidation. It can cause reactive oxygen species. It can cause a whole bunch of problems with these lipotoxic species. And that causes endoplasmic reticulum stress. It causes mitochondrial dysfunction. It causes signaling of inflammatory cytokines and then cell apoptosis. So all of those sort of things are the downstream effects of those lipotoxic species, okay? That is basically, in a nutshell, the pathogenesis of MASLD MASH. Here's another depiction of it. I like to put two things in twice so you can kind of see it from both ways. This is from the new 2023 AASLD guidelines on MASLD MASH. So this is similar to what I just said on the other slide. Risk factors for it. There's multiple modifiable risk factors that we need to be aware of. Metabolic syndrome has kind of a bidirectional association with MASLD MASH. Basically, if you have metabolic syndrome, you're at risk for MASLD MASH. If you have MASLD MASH, you're at risk for metabolic syndrome. The one I want to point out the most, though, is diabetes. 1/3 to 2/3 of people with diabetes are going to have MASLD MASH. Not only does it increase the prevalence of MASLD MASH in these people, it increases the rate of progression. You're more likely to progress to MASH if you have diabetes than if you don't have diabetes. About 50% of people with obesity are going to have MASLD MASH as well, but 7 to 20% of people are going to have lean MASLD MASH. They're not going to have obesity, okay? So just because you have a lean patient, if they have diabetes or if they have high blood pressure, high cholesterol, they should be screened for MASLD MASH. Some non-modifiable risk factors: age, genetics, ethnicity, sex, so just different genetics that can cause problems. Some of these genetic mutations actually are protective against MASLD MASH. Some of them are detrimental. Big detrimental one is the PNPLA3. That one we know can cause worsening disease and progressive disease. There's new therapeutics that they're testing out here. Dr. Lawis is here talking at the first year fellows course. He's big in these new therapeutics and research. They're looking at these silencing RNA molecules that will go and knock out these genes as therapeutic options in the future. So a lot of therapies are on the way for MASLD MASH. Who do we screen? So now we're getting into the diagnosis part of this. Who do we screen? We don't screen the general population because the prevalence of high-risk MASLD is not high enough to screen the general population, okay? We don't screen familial people. So if you have a family member with MASLD MASH, you don't necessarily need to be screened. But you screen people with risk factors. So if they have diabetes, or if they have obesity with at least one other cardiometabolic risk factor, or if they have elevated liver enzymes, those are the people you're going to screen. And how do you screen them? You get a history and physical, you get a CBC, you get a CMP, and that's going to help you calculate what your FIB-4 score is. I'll talk about that in the next slide, okay? Once you do that, you want to make sure you exclude other causes of steatotic liver disease, alcohol, drugs, all that kind of stuff. And you want to make sure you're checking for those cardiometabolic risk factors, because you need that to make the diagnosis, right? So you get your A1C, you get your lipids, you get your blood pressure, all that kind of stuff. If they have elevated liver enzymes, then you might want to consider doing a whole kind of shotgun thing for the chronic elevated liver enzyme workup. But if you want to refer them to GI, if you're not, like if you're in a primary care and you want to refer them to GI, that's totally fine too. These are some medications that are notorious for causing elevated or steatotic liver disease, okay? So those are some of the ones to be on the lookout for. Steroids, you know, worst perpetrator of all of them. Once you've diagnosed the MASLD MASH, then you want to stage the fibrosis. And that's because the higher the fibrosis stage, the worse the prognosis. And I think we all know this intuitively. Like when you have cirrhosis, that's a really bad prognostic indicator, right? But we want to pick out these people that we can actually do stuff for and actually make big changes for, right? So we want to pick out the people who are at risk MASLD MASH or advanced advanced fibrosis, right? So at-risk fibrosis is any fibrosis stage over 2 and above, and then advanced fibrosis is 3 or 4. We want to identify the stage 2 and above because then we can treat them with medications specifically targeted for MASLD MASH. All of the clinical trials out there right now that are testing new medications for MASLD MASH are only testing them for people with at-risk fibrosis. So you're not going to treat someone who has MASLD without fibrosis, and you're not going to treat low-risk MASH. You're going to treat stage 2 and above. Okay? That's why it's important to identify those people. Advanced fibrosis is important to identify because those are the people who are going to have complications of liver disease. You can get complications of liver disease from stage 3 fibrosis. You can obviously get complications of liver disease from stage 4 fibrosis. So that's why we want to identify those people. One way to do it is liver biopsy. It's invasive, it's costly, it can cause complications, and you're at risk for sampling error. So when you biopsy the liver, you're only getting about 1/50,000th of the liver. So that's why you want to make sure you're doing some of these other tests because they give you a global picture of the liver. They don't put a needle into a patient's side and all that kind of stuff. We're moving away from doing routine biopsies with MASLD MASH, and we're going more toward these non-invasive tests, these NITs, right? So there's serological NITs and there's imaging NITs. So we'll run through this real quickly. The identification of hepatic steatosis would be with ultrasound, with a FibroScan CAP score, or with an MRI PDFF. And then these other scores are the ways that you can identify people with at-risk MASLD MASH, okay? So your FAST score is one of my favorite ones because if you have a FibroScan, you do the FibroScan plus the AST, that will tell you the risk of someone having stage 2 disease and above. And if they meet that FAST score criteria, you can put them in a clinical trial, okay? Or you can treat them with medications. You have the MAS score, which is the MRI-PDFF, MRE, and AST. The MeFib, which is the MRE, MR elastography, and the Fib4. And then the CT1 MRI is actually a newer MRI technology that's coming out here. It helps you identify the amount of water and fibrosis in the liver. And so you can basically use it to say how much inflammation and how much fibrosis there is in the liver. So that's a new one that's on its way. It's coming down the pipeline. These are different cutoffs on these tests to determine, do you have advanced fibrosis, do you have cirrhosis? A lot of these tests are the same, but they just use different cutoffs at different levels, okay? All right, one of the things that you want to do is probably use sequential testing, okay? So in the primary care setting, we ask them to calculate the Fib4, and then we identify those people who are at higher risk or intermediate risk, and then we can do another test to decrease that indeterminate zone. So if you have a Fib4, you probably know that there's a high indeterminate zone between the values. Less than 1.3 is low risk, higher than 2.6 is high risk, but that 1.3 to 2.6 range is intermediate, so we don't really know what to do with them. If you do a second test, you're more likely to be able to group them into one of two categories, low risk or high risk, okay? So this is the AGA pathway that they recommend as far as what do you do when you're screening patients with MASLD MASH. So if they have any of those indications up at the top, 2 or more risk factors, type 2 diabetes or steatosis on imaging or elevated liver enzymes, those are the people you're going to test. And you're going to do all those history physical labs so you can calculate a Fib4. Remember, those are your risk factors, exclude excessive alcohol intake, and then when you're calculating the Fib4 is really unreliable for people that are under the age of 35. So you want to be careful when you're using that for younger patients, okay? And then you're going to group them into low risk, intermediate, high risk. If they're low risk, they can go back to their PCM, or they can have this repeated in 1 to 2 years. Intermediate risk needs a second test. High risk can basically go straight to hepatology. This is the EASL guidelines that just came out earlier this year. Basically, it reiterates the same thing. The one thing I will say is, if you're not able to figure out a secondary test because you don't have the ELF, or you don't have a FibroScan, you can have them do lifestyle modifications and repeat it in a year, and then that might be able to group them in 1 or 2 categories. Okay? So it's essentially the same pathway as the AGA pathway. It's newer. All right. Here's the treatment options that we have for this. I'm going to try to run through this really quickly so I don't get into Dr. Awad's time too much. But diet is one of the, sorry, hold on. Someone took stuff out of my slides, that's fine. So diet is probably the biggest thing that we gotta do. So we talked about this in the previous presentation, so I'm not gonna belabor the point. One thing I will say is, if they have low risk MASLD, they can probably still have a couple of drinks of alcohol per week. If they have at least at risk MASLD, so stage 2 and above, no alcohol is safe for them because we know they compound on each other, right? The other thing is coffee consumption. Caffeinated or decaffeinated is really helpful in these patients. So basically, you can tell them if they drink coffee, great. I recommend no added cream or sugar because that's extra calories. Doesn't have to be caffeinated. It can be decaffeinated or caffeinated, okay? But outside of that, everything I kind of said on the previous presentation goes with this as well. Exercise, same thing. It's essentially the same thing that I told you in the obesity talk, so I'm not going to belabor this. You want to improve that NEAT. When you're exercising, it's going to improve that muscle mass, and it's going to help them be more active, prevent sarcopenia, frailty, all that kind of stuff. Tailor it to the patient's specific needs. So a lot of times, the patients are going to have orthopedic problems. You want to tailor that to their needs. Weight loss, any weight loss is helpful, but your ideal is 10% total body weight loss. And that's because that is shown to improve not only the steatosis, but the inflammation, the ballooning, and the fibrosis. Obviously, you get some benefit with lower amounts of weight loss, but really the best bang for your buck is going to come from 10% at about 6 to 12 months. That's what I counsel my patients on. Make sure they're up to date on all their vaccinations, right? The liver helps to fight off infections. So if you have someone who has liver disease and they get acute Hep A or acute Hep B, they're more likely to develop fulminant liver failure as a result of that infection. So that's why you want to recommend vaccination for Hep A and Hep B and all the other things. This is all just kind of like general preventative care for these patients. Only approved current medication for MASLD MASH is this new medication called resmetirom. You might hear the term Resdifra. It was approved in March of this year. It works to help reduce the fat and the fibrosis. So when you compare the placebo to the 100 milligram dose, you get about a 20% improvement in steatosis in the MASH. You get about 11% improvement in the fibrosis. The 11% improvement in the fibrosis is not statistically significant, but that 20% improvement in the MASH resolution is statistically significant. Side effects are mostly GI side effects. This medication, I don't see lasting very long because it has one clinical indication and that's about it, right? So why use a medication for one specific disease when you can use a medication that treats a whole plethora of other diseases, right? Some other medications that have been tested that I don't recommend, or at least I don't recommend right now, vitamin E, pioglitazone, ursodiol, those are all been tested and the results are kind of like mixed for them. But when we get into the GLP-1s, again, we're studying these for MASLD MASH because they've been so effective in all these other treatments. And the trials on them are looking really good. So there's phase 3 trials for semaglutide, tirzepatide, and then I already talked to you about some of those other GLP glucagon receptor agonist ones that look like they're showing benefit as well. So if your patient has diabetes and MASLD MASH, this is your recommended therapy, the GLPs. The SGLT2 inhibitors might also have a benefit. Studies are way too early to really recommend the SGLT2 inhibitors right now. Statins are safe and effective in people with MASLD and MASH. A lot of people get really wigged out with statins in these patients. I always encourage them unless you have decompensated cirrhosis, okay? So if a patient comes in with MASLD and MASH, I put them on statins. Usually it's a lipophilic statin, like atorvastatin, because it helps with outcomes. It lowers their transaminases. It decreases portal hypertension. So I always recommend statins for people who have MASLD and MASH. If they have any comorbidities, you want to use medications that are beneficial for both MASLD, MASH, and their comorbidities, which is why I was saying if they have type 2 diabetes, use an SGLT2 inhibitor, use a GLP-1 agonist or combination agonist. Use statins if you need to for dyslipidemia. When it comes to hypertension, there was one study that I saw that recommended ACE inhibitors and ARBs as the go-to medication for people with hypertension and MASLD and MASH because there might be a benefit from the ACE inhibitors and ARBs with MASLD and MASH. We talked at length about this, so I'm not going to go into this. These medications, so all the bariatrics, are aiming to improve weight. They're not aiming to improve MASLD and MASH, but you might get that secondary benefit from them, which is why you can try these outcomes or these interventions, right? Endoscopic bariatric procedures, I didn't talk about in the last slide. These are things that help with weight loss again, right? So you have the intragastric balloons, which are fluid-filled balloons. You place them in the stomach for about 6 to 12 months, and it helps with weight loss. You do get weight regain after the fact, which is a little bit of a downside to them. But overall, they help with weight loss. We think they're going to help with MASLD MASH. We don't have any data to prove that. The other option is these gastric remodeling, the endoscopic gastric remodeling. These are basically you're doing a gastric sleeve endoscopically, okay? So it's less invasive. You're not having surgery. But basically, it's going to do an endoscopic gastric sleeve. And there's multiple different platforms to do it. Down there at the bottom, you have the transpyloric shuttle aspiration therapy and those endobarrier and the Revita duodenal mucosal resurfacing. Currently not FDA approved for anything. But these two therapies down here are treatment for obesity. These two therapies are treatment more for like diabetes, for metabolic disease, okay? So those two therapies on the left might not necessarily help with the weight loss. And then bariatric surgery, there's multiple different bariatric surgeries. It's indicated in people who have a BMI over 35 or a BMI between 30 and 35 with some weight-related comorbidities, okay? Big ones that I want to point out are the sleeve gastrectomy and the Roux-en-Y gastric bypass because those are the most common ones performed. So we can see adjustable gastric banding is falling out of favor because people don't really get good of a benefit from it, and you get complications from that band. It can slip or it can erode, that sort of thing. So that one's going away, but gastric sleeve right now is the most common bariatric surgery that are being performed. Caution with the gastric sleeve, though, because it can cause patients to have worsening acid reflux disease. Then we get to the Roux-en-Y gastric bypass. So we probably know about this one. It creates about a fist-sized gastric pouch. and then it's directly connected to the jejunum, and so you're bypassing some of the intestine and you're restricting how much patients can take in. And you can see estimated weight loss pretty damn good at 2 years. This biliary pancreatico diversion, or what's called a duodenal switch, is pretty good at weight loss. The problem is it's a very in-depth surgery, and there's a lot of complications that come from it. So we really aren't doing that one as much, right? These are two of the newer therapies that are out there, two of the newer surgeries that are out there. So you have the SADI-S, where you do a gastric sleeve, and then you do basically one anastomosis of the post-pyloric duodenum to the ileum, okay? So the reason why that's good is because you're not going to have any reflux through the pylorus, and so you don't get that bile acid reflux or anything like that. You're usually going to be left with a 250 to 300 centimeter common channel, so that means you're bypassing a whole bunch of the intestines. This is really good. Outcomes are better than the duodenal switch, so the complication rates are better. I think the duodenal switch has better weight loss outcomes, but the complication rates are better with this one. And then the one anastomosis gastric bypass, it's basically you make that fist-sized gastric pouch, and then you directly connect it to the lupa jejunum. Again, same kind of length of the common channel. I think the data on this is still new, so these aren't commonly performed procedures. This is the AASLD pathway for MASLD and MASH. If you want to take a picture of this one, I love this specific pathway. But that's all I have for you guys. The only other thing is I have my question slide. So we'll do questions, I think, after Dr. Awad's talk. But thank you all for your attention. I really appreciate it.